Next up, I'd like to invite Jan Dewar. She's the Nurse Director of Medicine, Surgery and Emergency from Mid Central DHB to talk about the experience in Palmerston North.
Well, thank you for allowing me to speak. As Alex said, I'm Jan Dewar at Mid Central, which for those that may not know is Palmerston North Hospital. And given my current heart rate, I'm really pleased there's lots of experts in the room, so yeah, no pressure. I'm wanting to tell you a story about some work we did with one of the wards, but just by way of history, we introduced the national chart in 2017 in November, so about a year ago. We'd had an early warning score chart there for 8 years already, so it was a good time for a refresh. Some staff were very committed to the old chart because they had designed it, so that was where we started with. I'll talk about that a little bit more. So I thought I'd start with the results first and talk about the success. So this is our whole of hospital. You can see that we put the chart in November, so we've had about an 80% reduction in our cardiac arrests. Hopefully that's going to continue, but we'll see. Each one gets reviewed and examined, so the ones we are having now are not having obvious deterioration over hours beforehand, so that's reassuring for us as well. Having the data has been useful for convincing people of the merit of the chart. And at the time I was doing a course, so I learned to do XMR charts, so you can be all really impressed with the quality of the fancy chart. So in my head, these people have got names, but I probably won't tell you what they are today. We started out, the CMO asked me if I'd lead this piece of work, and various people said, oh, such and such an SMO will be tricky. So such and such an SMO is my new best friend, because that was my approach, to ask that person to help me design the whole rollout and who should we involve, and what should we do. So I guess a tip for anyone starting is kind of pick your people that are passionate and have really strong views and get them on the inside, because that worked really well. Alex and Jenny came up and we managed to fill our lecture theatre with doctors and nurses to hear about the program and why that was important. So that really, really helped at the time as well. The clinical board supported us, along with the CMO and the DON, as sponsors. So yeah, that was a good start for us. I sat down with a group from the ward to look at, what is the process and what are we doing? And I know that's quite hard to read, but a couple of focus groups to look at what we're doing. And here's a lovely process where the patient feels unwell, you do some OBS, you total up the early warning score, you talk to the nurse in charge, it triggers something, you call a doctor or two, they come and make a plan or ring the SMO, they write it all down and you do it all, and that's really great. So that was really awesome. We were able to just stop there, and that was it done. So there's a concept of work as imagined, which was on the last slide, versus work as done, which is partly what I'll talk about now. I've grouped these up into kind of the themes that came out of those focus groups. So ISBA, which is a tool for communicating, wasn't being used consistently. People weren't always putting their contact details in the web page when they paged someone to come. There didn't seem to be a timely response from the medical staff always. There was a lack of escalating to SMOs for whatever reason, and people had opinions about that. The nurse wasn't always present when a review was being done and things weren't being documented. So although we had a really well understood process, we had some reality in there. So I'll leave you to guess who said these, but I thought I'd just put some comments that were made. Your web page, and they don't ring or come. Details are missing and you can't actually tell what the problem is. Junior nurses get pushed back from medical staff. I'm sure that doesn't happen anywhere else, so that's really great. They don't leave a number to call, which is a problem if you're putting a chest drain in or something and you're wanting somebody to ring and see what's going on. And this was my favourite. When you get to the ward, no one knows who sent the page and they've gone to tea anyway. So I realise that we're unique and this won't be something that the rest of you are dealing with. But that was that. So we thought, okay, what are we going to do? We need to come up with some change ideas, which we did, and decided that we would at least standardise the web page in this one ward and try and get that right. So we had a bit more discussion and decided what we thought was the ideal web page, and that had a few iterations as we tested. We educated the staff, so when you read educated, you might also think cajoled, pleaded, asked, begged, anything. We didn't threaten, but we had a lot of work there. We measured the compliance, which I'll show you in a second, and this is what we ended up with as the minimum requirements for a web page, which is the name of the patient, the score, why it was being triggered, the name of the nurse and the phone number, which does seem so obvious, but when you look at the pages that were coming, that wasn't always obvious. So I measured this by pulling a week's worth of pages sent from that ward over several months to see how compliant they were with including the details in the web page. We're having the pleasure of our certification audit at the moment, and a very observant auditor said to me today, "Is it web page or wedge page? There's a typo in your swim lane." I think looking at the pages we could rename it wedge page. I'm sure there's some interesting pages, but the ward did really well. They worked hard, and you can see there that they're very consistent now with what they're putting in the web pages. So that was all great, but alongside this we were doing another piece of work, and there was a bit of a problem, and that was around confidence in the tool. So as we started this, we got good old Survey Monkey out and got the nurses and doctors from that ward, 50% of the staff filled in this. So against the question, our current observations chart helps me identify patient deterioration early. You can see that 18% didn't think it did, 42% didn't really have an opinion, and 50% agreed. So we did have a bit of work to do there. So once again, presentations on evidence. We gave out pocket guides. We got opinion leaders to come and talk. We kept feeding back the data, and lots of visits and lots of positivity to the ward. And then we did the survey again, and against the question, our newly introduced observations chart helps me identify patient deterioration early. You can see that 8% was still neutral, 68% agreed, and 24% strongly agreed. So for us, for me, that was a really important thing. And we've been talking about communication and how important that is. So to get buy-in and people trusting that this is a good prompt and getting the right information fed up and down the line was really important. And I do need to give credit to the educator, our CNS who's here, the charge nurse and the RMOs involved. On the morning that we rolled out the chart, one of the RMOs in our group was giving medical handover to all the medical staff at 8 o'clock. His pager went off, he looked down and said, "It's an 8, be there in 10 minutes," to his colleague, which was perfect. I didn't even send that page, but that was really great. So I just wanted to give you a picture of the small piece of work we did in one ward, but it has really helped with our rollout and our rolling across. This is a photo of the team, just so that you can see we are real people. And for me, the outcomes to be proud of are that people are feeling confident, really confident, and they're using it properly. So they're recognising early, escalating early, and the response is timely. It might be a bit much to say that we're saving lives, but we're at least making a difference, and the hope is that we are. And I guess in the first 3 months we would have expected 10 cardiac arrests, and we had 2 for those 8 people that didn't have a cardiac arrest. I think that's a pretty positive result. I want to especially thank Gay Fell, our consumer, who has been on our governance group right from the start of the rollout. So she has sat through endless meetings while we talk about who should come and when and how long they should take in terms of escalation. So that's been great, because as we roll into the next piece of work, she's got really, really clear understanding of all those pieces. So I guess one other piece of advice would be to get a consumer in really early, even if it doesn't look specifically like consumery things, because that's been awesome. And also the ward team. The other thing that was helpful for me was doing the Improvement Advisor course through Ko Aotea, which the Commission supports. So if you want to go and do 10 months of not just learning XMR charts, but other things, it is really helpful because you start to look at, is an improvement really an improvement, and get some really good thinking around that. So it's just a plug for that at the end. So a very short presentation, and I hope it's been helpful, and happy to take any questions or feedback or talk to anyone later.